everyone had a chance to see the case. Brent or Dr. Daya, maybe we can start off with Brent. You have significant experience working in a rural emergency department. Again, 54-year-old woman with these vital signs. This is just a short cross-sectional clip of her presentation. As an educator as well, how would you sort of approach this patient if, let's say, you had even a student in the room or a student were watching this video? Sort of what sort of things could you glean from looking at this case?
Well, I agree with the comment that I think it was Mike just made, that she does not appear to be in any pain or distress at this time, and relatively stable vital signs. So, I think probably one of the things that I would probably do with this particular case, and one of the reasons that, to kind of get off topic for a second, one of the reasons that I like ReelDx cases like this is that in addition to telling the story, you get to look at the patient and you can see that she's not in any obvious distress. And so you can pause that there and you can talk to the students. And at this point, I would probably start asking them about their differential. Having not done a physical exam yet, I still think it's important for them to develop a differential diagnosis so that they can determine what physical exams they need to perform and which ones they don't. At this point, we're still trying to get the students to focus their physical exams so that they don't end up doing things like Weber and Renee and visual field tests on patients that present with chest pain. So I would probably have them work through a differential. And at this point, they've had a good chunk of GI, pulmonary, cardio. We haven't gotten into neuro yet, but hopefully, and yeah, GI too. So hopefully they would be including gallbladder disease, hiatal hernia, peptic ulcer, where they just got through cardiology. They may be including pericarditis, things like that, in addition to a suspected anginal episode, MI, or arrhythmia. So hopefully they could develop a differential of at least 7 or 8 possibilities, I would hope.
Great. And in terms of the differential, we actually have the actual outcomes here. We've curated this, and one of the authors put together the actual outcomes. But what things would you be thinking of? Clearly, the videographer asked about stress, which is obviously a diagnosis of exclusion. And I know I'm a pediatrician. I know that from a little bit of my adult training that women can present with atypical chest pain as they're having a myocardial infarction. What sort of things would you put on her differential diagnosis, like up front, seeing this case and seeing her vital signs?
At this point, her differential for me would most likely be GERD, possible biliary colic versus probably no other acute gallbladder diseases. Peptic ulcer disease without an obvious history for GERD, that's questionable. They said it could be anxiety disorder of some kind, even with the recent reduction in stress. You still can't rule out MI because, like you said, they usually present atypically in females, or they often present atypically in females. Those would be at the top of my differential at this point, I would say. I also noticed you were asking about how she slept the night before. I'm assuming that was to determine if she, awoke with a crick in her neck or anything like that, or if she had a restless night's sleep. She doesn't appear to be having any neck stiffness when she, looks at you and then looks away briefly. So that would be less likely as well.
Dr. Daya, do you have any other comments? Let's say she showed up at a quaternary care emergency department. You work obviously in an academic setting. Anything else you would add in terms of sick, not sick, and differential diagnosis approaching this patient?
So I think that first of all, you need to be very careful about the appearance. And so I think that yes, on the rough surface, you can say she does not look sick, but chest pain is a very subjective individual decision, and people can present looking very with acute coronary syndrome looking very mild in terms of their appearance. So you should not be fooled by the look of the cover, as they would say. So you need to be careful. I think that From an emergency medicine perspective, you need to always ask yourself, what do you need to do to instantly stabilize this person? Her vital signs seem okay. She should definitely be put on a cardiac monitor, and the first thing to probably do is obtain a 12-lead ECG. Chest pain, the biggest concern when you have chest pain as a presentation is going to be the life-threatening illnesses that we tend to worry about. So you want to think through acute coronary syndrome, be it myocardial infarction, non-STEMI, unstable angina. Those are the three that should cross your mind up front. Additional things to think about obviously would be dissection, pulmonary embolism, and then you get into the pulmonary pathology, you get into the GI pathology. The other thing to remember is that this lady had palpitations. She also has a history of hyperthyroidism. She takes methimazole. Each of those can be potentially problematic. Methimazole can cause an element of issues with your white cells that you need to be thinking about. And then you need to think about whether their thyroid and hyperthyroidism is part of the contributing factor. If she got tachycardic or had a arrhythmia episode, that might have been enough. Recent studies actually suggested men and women present similarly.
Can you say that again?
Because they tend to try to. Recent studies suggest that men and women present similarly when they present. So it's not as atypical. It's actually the elderly and the diabetic that present dramatically differently. But men and women tend to present similarly in terms of chest pain. Women tend to have a little bit more shortness of breath. The thing that women tend to do is they delay coming to the hospital longer because they tend to sort of things or they have other worry about. So that's, I think, one of the big things to remember. So to me, from an emergency medicine perspective, it's different than a primary care perspective. I don't know this individual. My job is to rule out the life threats, and I think that's how we teach the EMS folks. And simultaneously, you want to try to stabilize the person. So while you're doing the workup and you're getting the ECG, your worst possibility is it's a STEMI or a acute coronary syndrome of some kind, which could be anywhere from, as I said, STEMI, non-STEMI to unstable angina. And so you would start the therapy for that, which typically includes the 12-lead, and then usually we give a dose of aspirin to most individuals because it's a pretty benign therapy, yet has a dramatic benefit in terms of reducing its mortality rate. It drops your mortality by 25% if you have an underlying acute coronary syndrome. So that's typically what we'll do up front.
So I appreciate that, and we do have some students on the webinar, Mo. This is her ECG. It looks like she's a P wave before every QRS. It's hard to see exactly. It's a little bit rough. It doesn't look like she's in AFib. It looks to me like she's not in a tachydysrhythmia. I don't know, Mo, Brent, or Liz, if you have any comments about the ECG and her vital signs, but this was obtained, I know, within the first 10 minutes of her arrival. Clearly her heart rate was 70 upon arrival. Brent or Mo, do you have any comment on her 12-lead?
So I'll comment first. I think that you're missing leads 1, 2, and 3. So it's kind of, you don't have a complete picture. So you've got, 9 out of the 12 leads, not all 12. So we are missing the lateral leads, which makes it a little bit of a tricky situation. I agree. It's not normal sinus rhythm. That's good to know because hyperthyroidism can present with atrial fibrillation. And I think that as you look at the, you're looking for obvious signs of ischemia, which would be ST elevation. In the anterior leads, it's 2 millimeters in 2 contiguous leads. I don't see that. I don't see any ST depressions, which are another sign of ischemia, often reciprocal or actually evidence of a non-STEMI. So MI. So not seeing that, I think you feel reassured that this is the case. I think that the concerning thing you have is that she has one risk factor, and that she has hypercholesterolemia. We don't know about hypertension, but I'm presuming no. We don't know about her family history, which is something that's also not been asked yet. So those are important things to keep in mind, because if she has a strong family history, that can change dramatically, again, her risk. And I can tell you that you need to keep acute coronary syndrome in the back of your mind at all times, because it can really fool you. People can look very, very mild, yet be having acute cardiac ischemia.
So she, just to continue this case, the webinar, everyone, is a 30-minute webinar, so I just want to keep everyone on time. And Dr. Daya and Brent, I really appreciate your comments. Liz, do you have any comments from your standpoint? I know that you have significant history in this realms. Are there anything else that you want to add? We even have more of a differential diagnosis here in the actual outcomes than we've discussed here in the webinar. Do you have any other thoughts?
No, I think that Dr. Daya and Brent have really covered it, my same points quite well.
Great. So I'm just curious because, again, I'm a pediatric ER physician, so my training in adult care is pretty minimal. She had a normal CBC. I believe she also had a normal complete metabolic profile. Her troponin was 0.01. And it was repeated 4 hours later, and it was the same value. I believe she had another ECG as well, which was exactly the same. We had a comment prior to this, interestingly, on Twitter, that one of the physicians said that this patient should have probably been admitted for observation. And I'm just curious, knowing the data that we have here, in terms of her vital signs, her ECG, which was remained stable. Her vital signs remained stable for 4 hours, 2 negative troponins, and she was given, I believe, a GI cocktail as well. She was given aspirin up front. She was given some Zofran. She did complain of nausea, which is ondansetron, and she was given the GI cocktail, which is spelled wrong there. Nancy, we need to correct that. It's good that we're looking at it. And she was discharged. So my question to the group is this something that you would, is this a patient you would keep longer? Are there other tests that should have been done? What are some comments? Brent, she's in a rural emergency department and she has a PCP.
So I guess one of the things that I always take into consideration, especially in a rural setting, is is it a weekday or a weekend? If it's a weekday, her primary care provider's office is open, and a lot of times, at least in a rural setting, they'll have some openings or some availability to follow up with them the same day or the following day. They usually won't have urgent cares in rural settings for follow-up, and if it's a weekend, often the emergency department's really the only provider in town that's open. Also, if you're in a rural setting, you could admit her for observation, but I mean, other than having her on a telemetry, just kind of watching her, there's no cardiology in-house to consult on the case. So you're really just kind of literally just watching her for 4 to 8 hours to see how she does. In this case, I would tend to agree that, she seems a reliable patient. With the vital signs being stable and her symptoms resolved, unless my index of suspicion was significantly higher, I probably would feel comfortable discharging her, as long as herself and whoever was with her felt comfortable watching her at home, and as long as they had quick access to the emergency department. If they lived, an hour out of town, middle of winter, snowy roads, I'd probably be more likely to keep her and watch her for just a little bit longer. But otherwise, in town, close to home, with a reliable family member to watch her, I'd be okay letting her go home.
Mo or Liz, Mo, what are your comments? And Mo, you actually had mentioned some things in the differential diagnosis, like pulmonary embolus or PE. I'd be curious if you would have ordered more testing on her as her symptoms were abating, and or whether you would have kept her for longer than a 6 or 8 hour observation in the emergency department, considering her symptoms resolved over time.
So I think I would have probably done a chest x-ray, probably would have, to be thorough, would have checked blood pressures in both arms and looked for pulse deficits on the physical exam. I think that in terms of pulmonary embolism testing, she seems low risk. I probably put her through one of our risk stratification scores, either the Geneva score or the Wells score, and I think that she would have scored low risk, and probably at that point, some people might have done a D-dimer, others would have just let it go based on low probability. I don't think she's got a strong risk. She's not telling me strong risk factors. With regards to acute coronary syndrome, I think that you need to understand that in the current American Heart and latest guidelines that have come out, they suggest you combine the troponin, the delta troponin, which is basically 2 troponins, usually 0 to, depending on which level you're using, initial troponin and 1 3 to 6 hours later. You combine that with what's called a risk stratification score, and the one that a lot of people are using is the heart score. Others use the TIMI score. Others use the Vancouver rule. There are many rules, but if you were to combine those two, and she fell into a low risk category, then her risk for having a major cardiovascular event in the next 30 days is actually pretty low. It's less than 1%, in which case it's safe to actually send her home and then have her follow up with her primary care physician. I would be careful to say that this is non-cardiac chest pain. I think it's getting higher on the list as your pretest probability continues to drop with all the tests that you're doing, but it's always in the back of your mind because, as I've said before, you can be misled very easily. So what she needs ultimately is a follow-up, and they should, given the hypercholesterolemia, if she has a strong family history, for example, if she had a couple of risk factors, that might have put her into a higher risk category on the heart risk score, in which case you probably should keep her and do the stress testing in-house. So this is where I think the art of medicine is evolving as we get more of these decision-making tools. We combine with our physical exam, combine with our lab tests and other things to really decide the direction we go in. So it depends. We're missing some information which would make the decision-making a lot easier.
I appreciate that. And at least I know in children, I could speak around that. In peds emergency medicine, we're relying more and more upon clinical pathways. And are there clinical pathways associated with chest pain in either Brent, Liz, or Mo? You mentioned risk stratification scores. Are you using that? Is that Dr. Daya's rule when you actually see the patient, or is there a department-wide clinical pathway for chest pain, and you're actually going down that pathway and using those scores within the context of a clinical pathway to reduce variation?
I would agree with what Dr. Daya said. We use the TIMI score a lot of times. I think there's some other good ones. You mentioned the heart score. I think there's some better ones out there than the TIMI score nowadays. For PE, I tend to use the PERT criteria, and I don't know, I would be interested if Dr. Dayam has any experience with that. I've picked that up from a couple different providers that I've worked with, and I like it for the use of ruling out, or at least evaluating the likelihood of a PE and the need to perform either D-dimers or CT scans to evaluate for that. But yeah, I agree with what he said, that the use of those algorithms to determine likelihood of disease, of true pathology, is very useful in helping us minimize the invasiveness and the expense of the test that we perform, and also helping us preserve the safety of the patients and determining whether it's safe for discharge or admission.
Real quickly, we have a bunch of EMS providers and educators on the line here. Dr. Daya, do you have any one or two quick pearls as from an EMS director standpoint, wearing that hat? This woman is being transported. Any pearls that you would give from an EMS educator standpoint, seeing this clip? Let's say this video was during transport.
So I think, as I said before, these patients need to be stabilized. So I'd have her on a heart monitor, check her SpO2. If it's low, she should be on some oxygen. If it's above 95%, you don't need to worry about oxygen. I would treat her for presumed acute coronary syndrome, and then I would let things figure out. I'll say a couple of things. Do not diagnose anxiety in patients until you've ruled out all the life threats. I've seen patients like this brought to the ED with an acute MI with the diagnosis of hyperventilation. Similar with PE, it's the same thing. The PERC rule doesn't work in her. I think it's under 50, which is validated for, so you can't really use it on her. You have to use another rule. There are a lot of clinical decision rules. There are many out there. I think you need to look at what's out there. Some work very easily. Others are a little bit more problematic depending on what you have. Most of them take history, physical, and help you make a decision about further testing or the decision making of sending them home. I think this will continue to grow. We see a lot of chest pain, but unfortunately, we don't see a lot. Unfortunately, I should say, most of these folks don't have acute coronary syndrome. So a lot of this is really understanding the different rules we have out there and how they've been validated. So make sure you use validated tools and be careful. Always think bad before you think good.
That's really sage advice. I really appreciate it. We're closing into 30 minutes past the hour. Real quickly, Brent or Liz, could you just comment a little bit about how you might use this case in the teaching setting for the physician assistant students?
Well, these have become kind of invaluable tools for us in that oftentimes we're trying, without the video clips, trying to describe what a patient looks like, what they're going to say. And so it really is nice to be able to present these different pathologies to patients, to students, and then have them be able to have a visual that goes with that. And it's something that role playing and simulation doesn't do as well as actually having a real patient and say, no, this is what it looks like. And this particular case is a great example of chest pain that could be extremely serious, could be a serious MI, could be acute coronary syndrome that doesn't look like a patient that's in severe distress. And so, it's a great teaching case for that exact reason.
Great. Well, we're going to end now. There's one quick comment. Yeah. So any follow-up questions, please email Nancy@ReelDx.com or David@ReelDx.com. I'd just like to thank our panelists, Brent, Nancy, Liz, and Mo. I'm honored to have you all as panelists on our first webinar here at ReelDx, and I'm appreciative of all the panelists and also the participants that have come to join us today. And mostly, I'm thankful for all of our patients and this woman that actually consented to allow us to learn from her case. So thank you all, and I hope you have a great rest of the day.
Thank you.
Bye-bye.